Thank you so much, and thanks for the invitation to talk about some of the thoughts and some of the research that we've been doing. And I've been learning a lot from these communities. I'm always welcome to any feedback that anyone has at the end. So I think that what I was trying to accomplish with today's talk is, I'm sorry, these are my disclosures. My laboratory does have conflict management plans in place. I do have ongoing NCI funding and intellectual property with Perspective Therapeutics, and also intellectual property with Galera Therapeutics. I also receive funds from the NIH, both as PI as well as co-investigator. I'll try to minimize any bias in my talk. And the objectives that I was trying to accomplish today was to go understand the pathophysiology of kidney injury, kind of what we know so far from other injury models, because our knowledge in radioligand therapies is still very limited. I also want to share with you the challenges in assessing kidney function and dysfunction, as well as toxicity in current era. And I'll review what is known about kidney handling of the radioligand therapies and how they can impact the kidney health. And then I did a little bit of a mental exercise of potential cases and approaches of to highlight how by really doing monitoring of kidney health, we can hopefully maximize these therapies in patients that can tolerate it, but also do a more personalized therapeutic approach on those ones that they are at risk of kidney complications. And to accomplish those learning objectives, I divided the talk on start with a brief clinical context based on how I got involved in this field and some of the ongoing controversies. I'll talk I'll do a little brief talk on the mechanism of acute kidney injury-induced chronic kidney disease and how the tubular cells have a central role in it. I'll go over mechanistically how there are a lot of limitations to the tools that we have. And then I have some graphics on the interactions of the radioligand therapies with the kidney, and then I'll go over the cases. So hopefully with this, we'll be able to brainstorm at the end of potential ways of targeting these challenges. And so I think that everyone in this audience is very familiar with these with the NETTER trial, where really we were able to see that there was not a significant impact, or there was no evidence of significant toxicity when they look at patients treated with lutetium dotatate versus a control group. And I think that's something that, as I was reviewing this trial, things that came to my mind is the survival was poor. Like, you look at the number of patients that they have longer follow-up. And so I do know that currently the community is limited on the dosages based on the external beam radiation data. I also saw that there is no significant difference in kidney function between both of the groups. But I also wonder if this is a bias sample because your survival is lower. And then I think that now we're learning from clinical trials in nephrology that a more meaningful outcomes is the change in GFR, because just a calculated creatinine clearance between two different groups is sometimes it's more meaningful, the delta of how you start and how you end. I think that there are some studies that have tried to look into that in that way. This is one example. There is more in the literature. I just pick at a few of them, and you can see how they try to look at what is the median GFR decrease in between the groups. I think that this is another example with lutetium PSMA, where you see that the kidney function decline is more evident at later time points. Again, the number of patients start to be reduced as the time goes by, and I'm very empathetic, and I really believe that as a community, we have to work on finding a way of maximizing this therapy in the patients that they can tolerate it. But definitely the signature is there, and that's why it continues to be a concern. And then there's some reports of not just a kidney function decline, but also some other potential kidney manifestations, including thrombotic microangiopathy, that's pretty much manifest as patients that develop proteinuria and hematuria, as well as kidney function decline. And when I review these cases, you can see that from the time from the first RLT to the drop in the GFR, there is a difference from the time of the first RLT is about 7 months. So in my mind, they identify the manifestations like 7 months after they gave the first therapy. But they were not monitoring for these at different time points. So I really don't know how early these manifestations happen until there was a change in GFR. And so it ranges anywhere between 2 months and 7 months after they started the therapy and they identify the GFR decline. This is with alpha emitters with actinium. I think that's another concern, that they have identified patients that they have increase in serum creatinine at later time points. Not in all of them. And of course, hasn't been a very good correlation between the dose and the development of the kidney manifestations. And these patients have other additional risk factors, which makes it very challenging to point out what can be some specific risk factors, and if really there is a causality with the therapy and the kidney manifestations. And so in my mind, the more I get involved with this community, I recognize the frustrations and the challenges that we're encountering right now. And I keep thinking from the nephrology perspective is how can we optimize these radiopharmaceuticals? I'm always encountering my clinical practice oncologists doing dose adjustments or dose fractionations, or how can you really better dose these therapies to be able to complete the therapy and save the life of these patients, but minimizing these toxicities. But I truly believe, and I'm going to try to convince you in this talk, that using this approach by collecting a comprehensive baseline kidney health assessment, that we know really what is the patient's baseline, looking at different time points throughout the therapy, and then starting to explore biomarkers of kidney injury and kidney reserve. I really believe that this approach could enable future dose escalation in patients that can't tolerate it, and those adjustments in those ones that they are at risk of kidney complications, but they could still be eligible for these therapies if they're life-saving. Because at the end of the day, I think that the goal of everyone is to improve the therapeutic efficacy, the patient survival and safety, but also help the patients be able to have an informed decision according to their goals of care. And I think that this is very important, because also as a nephrologist, I see those patients that ended up in kidney failure, and I think that it's important to take that into consideration as well. And so this is kind of the overall view of why I'm here as a nephrologist, because there is still kidney complications that people has observed on patients treated with radioligand therapies. And I'm going to go and dive in a little overview of what is the known pathophysiology of AKI and how acute kidney injury can lead in chronic kidney disease. And so the kidney has filtration units that they are your glomeruli. And you know, you have these arterioles that they are really providing the blood flow to those glomeruli. And then you have all these reabsorption units that they're surrounded by this peritubular capillary, and there is a continuous exchange between solids and ions that they are absorbed and secreted, as well as toxins in this interstitium. The functions of the kidneys is removal of waste products and excess of fluids, as well as balancing minerals and chemicals, control blood pressure, erythropoietin for plaque red blood cell productions are also performed by the kidney, and also a lot of the bone health is done by the kidney. But what I like to remind everyone that image of one glom with one tubular segment and peritubular capillary is not the reality. In the kidney, there is a lot of interconnections. Like you have a lot of these filtering units that they are really interconnected with each other, and they have all these ultrafiltrate that they go, several of them, to these excretion unit. And so there is a lot of interconnection. It's not unidimensional. There is a lot of overlapping about all these nephrons. What we do know is that after a kidney injury that is severe enough, and this has been studied a lot in ischemia reperfusion models or in some nephrotoxic-induced acute kidney injury models, that when you injure enough some tubular cells, some of them undergo apoptotic cell death or necrosis, and then you do have some cells within the kidney tubulars that they are actually able to restore, proliferate, and restore some of those tubules. Unfortunately, sometimes those tubular cells, they undergo a different phenotype, and they call it G2M arrested tubular cell phenotype, that these tubular cells are really not completely normal, and they can have a pro-fibrotic and a pro-inflammatory phenotype, that they recruit a lot of pericytes, and then in the long run, and inflammatory cells, they ended up causing collagen deposition and this chronic inflammation. And those changes are irreversible and progressive. And if you look at all our endpoints, when we measure kidney injury, they are based on GFR changes. None of them are really evaluating the tubular interstitial compartment. And I think that that's a huge limitation that our current tools have. And based on those limitations and the knowledge that we have, there's been a huge push and drive in the nephrology community to improve the characterization of our kidney injury phenotypes, improving by incorporating some biomarkers of tubular interstitial damage or tubular reserve, both in adults as well as in pediatrics. And there was a recent ADQI consensus report, consensus meeting that happened earlier this year, and hopefully the recommendations specific for onco-nephrology will be coming later this year, early next year. But what we do know is that in the kidney injury community, or kind of the knowledge that we have, is that there are several biomarkers that have been studied or explored. They tell us about the area of the kidney that can be injured. There are several of them that are actually FDA approved. Some companies are using it to screen drugs and decide if they're nephrotoxic or not, and if they move forward with their utilization. Some of them are clinically available. Like I use cystatin C, I use beta-2 microalbumin, I use albuminuria, I use NGAL in my practice in the ICU. The other ones, and urine protein to creatinine ratio, the other ones, they are really more research-based, and you can't just order an assay, but you can get a license and evaluate them. And they tell you not just the site, but kind of what's going on. NGAL is lipocalin that is secreted by tubular cells when they're damaged. Same thing with KIM1 and LFBAB. There's some markers of stress. TIM2, IGF binding protein 7 is called NephroCheck, and there is also clinically available. There's some markers of inflammation, et cetera, et cetera. And so this is a nice reference to look and explore what we know about biomarkers. They've been used in different ways, not just to identify kidney injury, but also to identify if there is really the changes in serum creatinine or cystatin C can be just hemodynamic changes. And I'll go over it in a little bit, but I think now people are starting to feel better of when you have those little bumps in serum creatinine that they normalize and you don't see any other changes on kidney injury biomarkers. We are calling them more kind of like hemodynamic change more than a true kidney injury. And there is now these KDIGO guidelines to stage acute kidney injury. And I like this consensus document where they talk about not just injury, but recovery. I think that is also important to make those characterizations. They delineate very nicely this timeline variable. Am I right? When I started my training, we will call AKI anything that happened in between 7 days and 3 months. And more than 3 months was CKD. And I was always confused because I was like 2 months or 3 months is still acute. And so I did like that they separate a little bit, do more acute injury, and then these changes that can be persistent or they present later after the exposure, but they're really not at a steady state in a chronic stage. They also start delineating the severity according to the changes in serum creatinine as well as to urine output. And so then we have patients that they can have stage 1 AKI when you have 1.5 increase of your baseline serum creatinine, and that's important, is your baseline serum creatinine, so where do you start? Or someone that goes to 3 times the baseline creatinine. I think that they also try to highlight that creatinine is not the holy grail in kidney injury. And so they start discussing the presence of subacute kidney injury or lack of full kidney recovery where your creatinine goes back to baseline, but you have still evidence of injury by or damage by presence of proteinuria, albuminuria, or abnormal kidney injury biomarkers. And you see more and more reports in the literature of these kidney injury phenotypes, where when you have a patient that doesn't have any evidence of a functional or damage biomarker, it's kind of normal, am I right? And when you have changes in your serum creatinine, but you don't have damage biomarker, it's kind of a dysfunction, but not an injury. And then when you have a damage biomarker plus a dysfunction, you really have acute kidney injury, ATN, interstitial nephritis, glomerulonephritis, like a good a more robust kidney injury insult. And then as a clinician, this is something that I see every day in the clinical practice. You have those patients that they come, they have AKI, and they have a rapid reversal. On those patients, I think we're learning that they have lower risk of long-term complications. We have others that they have like the severe persistent kidney injury. It doesn't go back to baseline. Other severe persistent, severe recurrent, you see their creatinine kind of bumping. When I think about radioligand therapies, I think more of did something happening here with a subclinical kidney injury that we were not able to identify with current tools, and then you just see this progression. We're getting better at identifying major adverse kidney events. And so when you look in the literature, we're talking about after an insult, what happens 30 days, 3 months, and 1 year after. That's with the mindset that 30 days, you're still in that kind of acute or AKD phase. 3 months, if you see something persistent for 3 months, I think in our mind as nephrologists, we think that that's more of a chronic change. And can something at 3 months predict what happens at 1 year, 3 years, and 5 years? There is a lot of modeling and predictive models trying to identify some potential phenotypes that can predict the longer outcomes. And the reason is because I think just like in the radioligand therapies in other kidney injury phenotypes, we're really trying to understand how we go from this phase to this chronic phase. We do know from very well-established KDIGO guidelines in chronic kidney disease that patients have risk of progression, and that's intrinsic. And it can be due to diabetes, hypertension, or other primary intrinsic patient characteristics, aging. But I like to cite this heat map because I use it every day in my practice with my patients. If I have someone that comes with a mild GFR decline, that they just come for a level creatinine, but that patient doesn't have hypertension, doesn't have proteinuria, doesn't have albuminuria, I tell them your likelihood of having kidney function decline is very low. But if I have a patient that comes with, I don't know, a mild kidney function decline, but they have significant proteinuria, I do talk to them of we have to find out why, or we have to do something about it. And we do know that with aging, and it's sad to say 30 to 40 years, your aging starts because I'm kind of there, but it is true, is we all have reduction of our GFR about 1 ml per minute per meters, 173 meters squared per year after you're like 30 to 40 years old. And if you start at 90 or 120, that means that by the time that you're 60, your GFR may be like 60, and it's normal for your age, as long as you don't have any proteinuria, hypertension, or albuminuria. And so I think that you in the adult population, you will identify patients with mild GFR decline, but if they don't have any other features, I don't think that we should limit therapies for those patients. But when you have someone that is in your red, I really think that those patients, we believe that there are sustained risk of having GFR decline of about 5 mLs per minute per 1.73 meters squared per year, which is kind of meaningful in my mind. I think it's more meaningful not having adequate survival, but it's something to discuss and take into consideration. And so what are the current limitations of the tools that I told you? Those are how we classify acute kidney injury, acute kidney disease, and chronic kidney disease, and the prognostic features that we have. But I think that a huge limitations that we have in nephrology is that the kidney has a lot of functions that we're not addressing. The kidney is not just a filtration unit, but it's also a reabsorption unit, a secretion unit, an excretion unit. And I like this kind of busy kind of the scheme, but it gives me a mindset. I always remind people that your GFR, you're constantly filtrating 160 liters per day. If you didn't have your kidneys absorbing all this amount of salt and all this amount of bicarb, we will all die. And so a lot of that absorption is done by your proximal tubule cells that is actively and through sodium to potassium ITPase and some solute drag. Your absorption of all these solutes is happening here. Also, your tubular cells are doing a lot of the waste and toxin secretions, and there is a lot of adaptive changes that your kidney does for you. If you have a high protein load meal, your GFR changes, and that's a physiological change. It's not abnormal. If you're dehydrated, your GFR changes. And so you can have just physiological GFR changes that they are not accounted when you just have one snapshot. The other thing is that the secretion of urine toxics and drones, as well as metabolic functions, are not accounted frequently, not with the current measurements that we have available. And the kidney does a lot of gluconeogenesis, ammonogenesis, activation, and metabolism of a lot of the drugs in the tubular cells. So this is a huge limitation of GFR. So when people ask me, how should I measure GFR? What is the best way of measuring GFR? I always like to remind people that GFR is among many functions. You can have biological variability, both in your measure as well as your estimate GFR, and analytical variability. They both are very equally important. And so as I measure hydration, protein load, there are some conditions affecting the true GFR. The analytical variability can happen due to non-ideal properties of the exogenous filtration markers, measurements errors that also happen. The estimated GFR, they can be the biological variability, but also the concentrations of the endogenous biomarkers can change, for example, in creatinine because of muscle mass amputations, there are many of those variables. Current markers used to estimate the glomerular filtration rate are creatinine and cystatin C. And I highly recommend using both of them because one overestimates GFR, the other one underestimates GFR. And the data that we have so far suggests that the average of both of them is more accurate. And this is very nicely reviewed. This is another reference that I highly recommend to review. It was a statement from the American Society of Onco-Nephrology where they review all the different studies on GFR estimates or measurements in the oncology population. And as you can see, additional studies are needed to assess the accuracy of other validated GFR equations in patients with cancer. Given the importance of accurate and timely GFR assessment, we advocate for use of validated. And so that means CKD epi in current state of to estimate GFR using both creatinine and cystatin C. In those patients that they are borderline eligible, you should highly consider measuring GFR. And despite all the efforts and everything that we want to do to improve GFR measurements, we're really not accounted for the renal functional reserve. And so if I remove, and I tell people this example all the time, if I remove one kidney from you today, tomorrow your creatinine is going to be the same and your estimated GFR is going to be the same. You can have a significant nephron loss without changing your serum creatinine. And the kidney undergoes a lot of hyperfiltration and hypertrophy to try to compensate and maintain that GFR. And so when you have a subfunctional damage, you are able to compensate by your renal functional reserve significantly reduced. When you have significantly higher damage, that's when you start seeing your changes in your biomarkers, But for that, you need more than 50% reduction of your kidney mass. And the other additional considerations is on oncology. We do have other drugs that can cause kidney injury that is not manifested by changes in serum creatinine. So you can have a vascular injury that just manifests as proteinuria and hematuria. You can have interstitial injury that they can have concentrated defect. Perfect example is cisplatin. It can cause magnesiuria, electrolyte wasting. It is a true tubular injury, but sometimes the patients have a very mild increase in creatinine. Sometimes they do have a severe AKI, but not always. And then some glomerular injury, like, for example, vascular endothelial growth factor inhibitors that can cause proteinuria. Tyrosine kinase inhibitors also can have proteinuria and TMA. So there is a lot of other drugs that can be causing another kidney manifestations. They can start days after the exposure. It doesn't have to be the same day. Most of the time when I get consulted, I look what happened the week before, because most of the time it's like somewhere in the first 10 days. They can be present with or without changes in serum creatinine. And when the serum creatinine is increased, it's very obvious and people call us. But I think now we know that even having those electrolyte changes, for example, cisplatin has impacted the long-term outcomes. And so, of course, I gave all this talk about the kidney, am I right? But how is this relevant to this community? And I think that what we know in some radioligand therapies with a small molecular weight is that they are freely filtered by the glomeruli, and either cutoff is less than 30 to 50 kilodaltons, and then they can really get uptake by the proximal tubule cells through some endocytic receptors like megalin. They can also be transported from your peritubular capillaries and be secreted, but they do go through the tubular cells by organic ion transporters and cationic transporters. They can also have receptor-specific binding. Am I right? Some of the receptors that we are targeting in radioligand therapy are also expressed in kidney tissue. And for example, melanocortin is expressed in the glomeruli, PSMA is expressed in proximal tubule cells and the Bowman capsule. And so all this is based on some human protein atlas that we look, or in mouse data. I haven't done biopsies in patients to look at it, but that's based on the information that we have. But in my mind, currently we're working only in inhibiting the uptake by reducing the endocytic uptake of these radioligand therapies by blocking megalin-dependent tubular uptake. But we're really not accounting for any of the other ways that they can get into the tubular cells. Once that they get there, what it's thought to happen is that they get trapped within the lysosomes, and they, in the tubular cells, they can release the radionuclide can release their either alpha beta emitter energy and cause tubular injury. I've been asked a lot if that causes glomeruli and is not enough to reach the glomerulus, and what does it reduce GFR? And I tell them primary tubular injury per se can be a good driver of CKD progression. So it doesn't need to make it the alpha or the beta to the glomeruli. Just causing the tubular interstitial injury can be enough to cause damage. Unfortunately, the mechanism is not very well understood. Everything that we know, a lot of it is being extrapolated from external beam radiation. Is believed to cause DNA damage through double-stranded breaks and cause tubular, maybe some senescence and fibrosis. And the manifestations are expected more after 6 months, the majority of the time, but that's what people has reported in the clinical practice. We have some knowledge from preclinical models. I know that humans are not animals, but when I start looking at all these reports, I always look at the histology. Am I right? And the first thing that caught my attention when I look at that is if you look at your gloms, they're not that bad looking, but you see a lot of tubular interstitial damage. And so that's why in my mind is these radioligand therapies, when they cause injury, it seems to me that it's more to the tubular interstitium. This is another preclinical model with an alpha emitter. This is with actinium. And then you can see how at 10 weeks, they didn't see as much changes, but how the changes start being more present at 20 weeks, 25 weeks. And then you can see that it's more progressive, and this is a control. And so again, it's when does it start? I think that that's a very interesting ongoing research question that we're trying to address in my lab. And then in this other study in alpha emitters, you can also see that despite those changes, you don't see any changes on the kidney functional biomarkers. In mice, it's widely used BUN because mice don't have a lot of creatinine or muscle mass. But look, you start seeing the changes more like 20 weeks after the injection. So it's kind of late to identify. This study, I like to cite it and show it because to me, this is, as a nephrologist, very important. I think that this group did a great job of how important it is to recognize early the potential risk of toxicity, because it can be modifiable. And so to me, that's very important. They show that if they start early, this is an ACE inhibitor, but this is a mineralocorticoid receptor blockade. Am I right? You can significantly reduce the kidney function decline. And I think if we understand more the mechanism, we can hopefully identify what is a more nephroprotective approach on these therapies. We got involved because I really believe that something happens in the early time point and we're just don't measuring and we don't have the biomarker that can identify that. And so we worked with Perspective and we did a dose escalation study. We did not give any amino acids. We intended to cause injury. And as expected, we didn't see any changes in the kidney functional biomarkers until 28 weeks after. And then 7 months after the therapy, you can see the severity of the tubular interstitial inflammation. The tubular injury, the inflammation, and the fibrosis is more severe than the glomerular changes. But we measured one of the tubular injury biomarkers. We measured several of them, but the one that had a cleaner signature was urine NGAL. And we saw a dose-dependent increase. These are mice that they don't have any other precondition to make them susceptible to these. All they got is this therapy. And so we saw a very dose-dependent increase. It highly correlated with the dose. But what was very interesting to me is that the level of urine NGAL had a decent correlation with the fibrosis happening 7 months after. So in my mind, there was some hope of maybe biomarkers can help us identify a subclinical kidney injury that can predict patients at risk of long-term kidney complications. We also look at tubular reserve biomarkers like urine EGF. We saw that they also are reduced after the therapy. We just haven't done recurrent insults to really see if that can be another tool. And so then I'm going to move to the hypothetical what if, am I right? And this, I struggle a lot in my head, and I'll be open to suggestions and feedback from the audience. But let's say that we try to identify a patient at risk before the exposure. And so if you perform a kidney health assessment and give this name because that's what is cited, but really you're trying to identify any predisposing risk factors from that population that can increase the likelihood of that patient having acute kidney injury. And then you really do a baseline assessment of the current tools that we have available. That is a very good estimate of their GFR using up-to-date equations, both statin and creatinine based. You evaluate that that patient has any evidence of damage. Do they have proteinuria? Do they have hematuria? If you're interested in discovery of new biomarkers, you get baseline biomarkers measurements or bank samples. Am I right? And then if you have a patient that is a 60-year-old male who has very well controlled hypertension and diabetes, that has a GFR of 50, that could happen to any patient at that age. But that patient doesn't have any albuminuria or any proteinuria. And this is where it gets confusing, because to a nephrologist, is in acute phase, we look at proteinuria. But for long-term prognostic indication, we use albuminuria because it's more sensitive. So depending on what you're trying to accomplish is the tool that you may want to use. But in my mind, this patient is here, And so maybe that is the patient population that has lower risk of progression, and that patient population is where you can try to identify the tolerated dose. Am I right? And there are a lot of tools that have been validated in the chronic kidney disease. Again, it's based on long-term predictions, but I've been with this community a lot, and I see a lot of people very savvy in math and modeling. And so I think that these are some validation tools that can be used as well. And you can predict the likelihood of that patient of having end-stage kidney disease or requiring dialysis. Am I right? These predictive equations also give recommendations of if you have this risk, how can you minimize it on a patient by using ACE inhibitors, SGLT2 inhibitors, or mineralocorticoid receptor blockades. And in my mind is a way of identifying which are the population that could be more feasible to do a dose escalation. Let's say that you have a patient that is the same patient but has poorly controlled hypertension and diabetes, and also receive platinum chemotherapy that is and a high dose of platinum chemotherapy. And when you get the baseline parameters, that same patient has the same GFR, but then has proteinuria and albuminuria. And so I think that in my mind is what is the cause of this proteinuria in this patient? Am I right? Do you need any workup? Or if that patient really needs this therapy right now and you don't want to delay it, at least you should try to get that patient some potential further diagnostic workup that can help guiding the therapy. Because in my mind, that patient is here. And so that patient is at higher risk of having kidney function decline. And so then I think that in these cases, at least you should get involved someone on this patient really needs this therapy, but what can we do to mitigate their risk? And again, it's because for this equation, when I see the survival of these patients that they're very sick, I think that they need more the therapy, am I right? But at the same time, you can see that the risk for end-stage renal disease is about 3.75%, but you can have the patient risk, the early identification, and the collaborative work can really hopefully reduce the risk. If that patient really needs that therapy, then knowing the nephrologists that they were exposed to a potential risky therapy, then they can be more aggressive to their nephroprotective approaches. That is before you start the therapy, am I right? But what about those patients that you're trying to identify or follow along the way? And the way I see it is, would you monitor the before and after the exposure to see how the patient is tolerated? Number one, because if they develop a complication, was it really my therapy that caused it? Number two, if there was no complication, can you do dose maximization? Number three, if the patient had a mild complication, early diagnostic workup and therapy could help tolerating further doses. Or number four, if they have severe complications, really there has to be a discussion of alternative according to the patient's goal of care. And again, to a case presentation of what happens frequently right now, this patient had well-controlled diabetes and hypertension, and their GFR was fine. They got the therapy, and then a month later, like the cases that I showed you, they present with swelling, hypertension, hematuria, and proteinuria, and the patient had a little bit of GFR decline. And then the question is, well, it was a month after, was this the RLT, or it was 3 months after, was it the RLT? And really, I don't know, because I don't know if this patient had those complications even before you gave your therapy. Compared to you have this patient that has this controlled hypertension, but got the chemotherapy, platinum, and maybe is receiving a TKI or an mTOR that is known to cause proteinuria. And then when you're doing your baseline assessment, the proteinuria is there. Then you can have the discussion of, does this patient need the TKI or the mTOR inhibitor? Do we need to do some nephroprotective approaches like an ACE inhibitor to reduce the proteinuria? Or do we delay, or do we just go with it, but knowing that if the patient develops that proteinuria, it was already there? And in the long term, I think that albuminuria is when it becomes more meaningful, because if you have a patient that had other risk factors, but at the baseline, they were with adequate GFR and proteinuria, but then in this 1 month, 3 months, or 6 months, they develop a GFR decline and proteinuria or albuminuria. I don't know if it's the RLT alone or everything else. It can be cumulative. But in my mind, these patients have progressed from here to here. And it's important to then do an early intervention so we can hopefully reduce the risk of progression. But I put these because these are therapies that nephrologists are still not very familiar with. So if you guys don't educate the nephrologist when you do the referral of this patient was exposed to this potential nephrotoxic therapy, and their baseline was here, and 1 year later is this, many times all they get the nephrologist is a single snapshot, and they may not be as aggressive at being proactive on therapy. Because at the end of the day, what I see is that you have different ways of improving the patient care on this population that they need these therapies. You have a lot of opportunities in the peri-RLT therapies, am I right? You can try to see if you can minimize any other additive insults. You can try to determine causality if you have the baseline. Also, you can try to see if during the therapy there are other mitigating strategies that you can use. But also, after the therapies are provided, if you identify the kidney complications, I really think that we have an opportunity to reduce the kidney function decline instead of waiting for the GFR to reduce. And I think that I take you to that paper that I know is animal models, but I think it gives me hope that there is a way of reducing the kidney function decline. And so what I'm hopeful that I was able to convince you is that I really believe that a comprehensive kidney health assessment and kidney injury biomarkers could be used to predict acute and long-term kidney complications. A comprehensive kidney health assessment and kidney injury biomarkers could help identifying timing of injury, not only in RLTs, but when patient encounters subsequent nephrotoxic exposures. Comprehensive kidney health assessment and kidney injury biomarkers could help developing personalized medicine. I think that if we're able to account other variables that can make this predictive model better, it will significantly impact patient care. And that's the part that I believe that biomarkers could provide injury mechanistic information and therapeutic window in this patient population for other potential nephroprotective approaches. And so those are my ideas and things that I've come up with talking from nephrologists as well as radiation oncologists, as well as the nuclear medicine community. But at the end of the day, these are the people that I really brainstorm all the ideas. And we're doing experiments in the lab to try to understand how the injury happens and potential nephroprotective approaches. But this is a very fascinating, evolving field, and I'm grateful for everyone's feedback. Thank you.